What would drive a trauma surgeon with 12 years of experience to question everything they thought they knew about the human body and the limits of medical intervention? In today's story, you'll discover what happened during one unforgettable night at Metropolitan General Hospital that challenged every principle I had learned in medical school and left me wondering if some cases defy all logical explanation. But before we begin, make sure to subscribe to the channel and hit that notification bell so you never miss our medical stories. Leave a comment below telling me about the most unexplained experience you've ever had, and stick around until the end because what I witnessed that December night will leave you questioning the boundaries between medical science and the impossible. There are moments in every surgeon's career when you realize that despite all your training, all your experience, and all the advanced technology at your disposal, there are still mysteries in medicine that cannot be easily explained or understood. I have carried one such moment with me for over 2 years now, and only recently have I found the courage to share what happened during what should have been a routine trauma surgery. My name is Dr. Sarah Martinez, and I am a board-certified trauma surgeon at Metropolitan General Hospital in Chicago. For the past 12 years, I have dedicated my life to emergency medicine, working in some of the busiest trauma centers in the country. I have performed thousands of surgeries, saved countless lives, and witnessed the incredible resilience of the human body under the most extreme circumstances. Throughout my career, I have always prided myself on maintaining a rational, evidence-based approach to medicine. I believe in the power of modern surgical techniques, advanced diagnostic tools, and the systematic protocols that guide trauma care. I have seen patients recover from injuries that seemed impossible to survive, and I have learned to trust in the predictable patterns of human physiology and the body's remarkable ability to heal. But the case I am about to describe challenged everything I thought I understood about trauma surgery and forced me to confront the possibility that there are aspects of human experience that exist beyond the scope of conventional medical understanding. The events took place on December 18, 2021, during what started as a typical Saturday night shift in our Level 1 trauma center. Metropolitan General serves a population of over 2 million people, and our emergency department sees an average of 150 patients per day, with trauma cases accounting for nearly 30% of our admissions. I had been on duty since 6 in the evening, and by 10 o'clock, we had already handled several serious cases, including a multi-vehicle accident, 2 gunshot wounds, and a construction worker who had fallen from scaffolding. The pace was demanding but manageable, exactly the kind of controlled 10:47 p.m. hour chaos that I had grown trauma alert accustomed to over the years. At system activated with an incoming ambulance carrying a 24-year-old female who had been involved in a severe motorcycle accident on the interstate. The paramedics reported multiple trauma with suspected internal injuries, significant blood loss, and an altered level of consciousness. The patient's name was Jessica Chen, and according to the initial report, she had been traveling at highway speed when her motorcycle collided with a concrete barrier during a sudden rainstorm. When the ambulance arrived, I could immediately see that this was going to be a complex case. Jessica was unconscious. Her vital signs were unstable, and she had obvious signs of severe trauma, including a possible head injury, chest trauma, and what appeared to be significant abdominal injuries. Her blood pressure was dangerously low, indicating substantial internal bleeding, and her breathing was labored despite the oxygen support provided by the paramedic team. We immediately transferred Jessica to Trauma Bay 2 and began our primary assessment following standard trauma protocols. Dr. Michael Roberts, our chief resident, assisted with the initial evaluation while our trauma team worked quickly to stabilize her condition and prepare for emergency surgery. The CT scans revealed extensive internal injuries, including a lacerated liver, damaged spleen, and possible traumatic brain injury with signs of increased intracranial pressure. Based on these findings, Jessica required immediate surgical intervention to control the internal bleeding and address the life-threatening injuries. We prepared Operating Room 3 for an emergency exploratory laparotomy, and I scrubbed in along with Dr. Roberts and our surgical team, including OR nurse Linda Patterson and anesthesiologist Dr. James Wilson. As we began the surgery at 11:35 p.m., Jessica's condition was critical, but not unusual for the type of trauma we regularly encounter. Her injuries were severe, but I had successfully treated similar cases many times before. The surgical plan was straightforward: control the bleeding, repair the damaged organs, and stabilize her condition for post-operative recovery. However, as we opened Jessica's abdomen and began to assess the extent of her internal injuries, something occurred that I had never experienced in my 12 years as a trauma surgeon. Despite being under deep general anesthesia with all the standard monitoring equipment showing that she was completely unconscious, Jessica began to speak. At first, I thought there might be a problem with the anesthesia delivery system, or that Dr. Wilson had made an error in calculating the dosage. Patients occasionally experience awareness during surgery, but it is extremely rare and usually involves brief moments of consciousness rather than sustained verbal communication. But Jessica was not just briefly aware. She was speaking clearly and coherently, providing detailed commentary about her own surgery, while remaining physiologically unconscious according to every monitor and assessment tool we had available. "Dr. Wilson, check her anesthesia levels," I instructed, assuming there must be a technical explanation for what we were witnessing. Dr. Wilson immediately reviewed all the monitoring equipment and anesthesia delivery systems. "Everything is functioning normally, Dr. Martinez. She's receiving adequate anesthesia for surgical procedures. Her brain activity monitors show patterns consistent with deep unconsciousness, but she's obviously conscious and communicating. This was medically impossible." Jessica's EEG readings indicated that her brain was in a state consistent with general anesthesia. The expect signs reflected physiological response to vital surgical anesthesia, and she showed no signs of movement. Yet she was speaking in stimulation. A calm, clear voice or physical response to surgical, describing what Dr. Martinez she could see happening during her own operation. "I can see that you're working on my liver right now," Jessica said as I carefully examined the laceration to her hepatic tissue. "The bleeding is coming from the left lobe, about 3 centimeters from the falciform ligament. You'll need to use electrocautery to control the smaller vessels before you can repair the main laceration." I paused my surgical work and looked at Dr. Roberts, who appeared equally bewildered by what we were hearing. Jessica's assessment of her injuries was not only accurate, but demonstrated knowledge of surgical anatomy and technique that would be impossible for someone without medical training to possess. "Jessica, can you hear me?" I asked, still trying to understand what was happening. "Yes, Dr. Martinez. I can hear you clearly. I can also see everything you're doing from up here. I'm watching the surgery from above the operating table." This statement was particularly disturbing because it suggested that Jessica was experiencing some form of out-of-body consciousness during her surgery, observing the procedure from a perspective that should have been physically impossible, given her position on the operating table. "Dr. Wilson, how is this possible?" Dr. Roberts asked. "She's completely anesthetized according to every measurement we have, but she's not only conscious, but seems to have knowledge she shouldn't possess." "I don't have an explanation," Dr. Wilson replied. "I've been an anesthesiologist for 15 years, and I've never encountered anything like this. Her physiological responses are exactly what I would expect from a patient under adequate surgical anesthesia. But clearly her consciousness is active in ways that our monitoring doesn't detect." As we continued the surgery, Jessica provided ongoing commentary, that demonstrated not only awareness of the surgical procedure, but also detailed knowledge of medical terminology, surgical techniques, and anatomical relationships that seemed impossible for someone without extensive medical training. "The bleeding from your spleen is more significant than it initially appeared," Jessica observed as we worked to control hemorrhaging from her splenic injury. "You might want to consider a splenectomy rather than attempting repair, given the extent of the damage and my current blood loss." Her suggestion was medically sound and reflected sophisticated understanding of trauma surgery decision-making that would typically require years of medical education and surgical experience. "Jessica, how do you know these medical terms?" I asked while continuing to work on her injuries. "According to your chart, you're a graphic designer with no medical background." "I don't know how I know these things, Dr. Martinez," Jessica replied in that same calm, detached voice. "It's like the information is just available to me while I'm in this state. I can see not just what you're doing, but why you're doing it and how it affects my body." What made this even more unsettling was Jessica's ability to predict complications before they occurred. As we worked to repair her liver laceration, she warned us about potential issues that we hadn't yet discovered. "Dr. Martinez, you're going to encounter some adhesions near the hepatic flexure that will complicate your approach to the posterior aspect of the liver," Jessica said. "There's also a small perforation in my duodenum that you haven't found yet, about 2 centimeters distal to the pylorus." I carefully explored the area she described and found exactly what she had predicted. The adhesions were significant enough to require additional dissection, and the duodenal perforation was small, but would have been missed during our initial assessment. These findings were not visible on any of our preoperative imaging and could only have been discovered through direct surgical exploration. "This is impossible," Dr. Roberts whispered to me as we worked to repair the duodenal injury that Jessica had somehow known about. "She's describing internal injuries that we couldn't have detected before opening her abdomen." The most disturbing aspect of Jessica's condition was not just her impossible consciousness during surgery, but her apparent ability to access information that beyond her surgical immediate sight. As we continued working, she began providing details about other patients and hospital operations that she couldn't possibly have known about. "Dr. Martinez, the patient in OR2 is having complications with his appendectomy," Jessica announced during a quiet moment in her procedure. "Dr. Stevens is going to need to extend the incision because of extensive inflammation and adhesions. The appendix has already perforated." I asked Linda Patterson to check with the charge nurse about the status of OR2. Within minutes, she confirmed that Dr. Stevens was indeed encountering complications during what should have been a routine appendectomy and was preparing to convert to an open procedure due to a perforated appendix with extensive peritoneal contamination. "Jessica, how could you possibly know what's happening in another operating room?" Dr. Wilson asked, his voice reflecting the same bewilderment that we were all experiencing. "I can see the entire surgical suite from where I am," replied. Jessica's like I have access to information about everything that's happening in the hospital right now. Dr. Peterson in OR4 is having difficulty with a gallbladder removal because of severe scarring from previous surgery. The patient in the emergency department who came in with chest pain is actually having a heart attack, not just anxiety like they initially thought. Each of Jessica's reports proved to be completely accurate when we verified them through our hospital communication systems. She was providing real-time information about medical situations throughout the hospital that she couldn't possibly have access to from her position on our operating table. Throughout this extraordinary surgery, Jessica's vital signs remained stable and consistent with deep surgical anesthesia. Her blood pressure, heart rate, and oxygen saturation levels were exactly what we would expect from a patient under adequate anesthesia for major trauma surgery. Her EEG readings continued to show brainwave patterns consistent with unconsciousness, yet she maintained perfect awareness and communication throughout the entire procedure. Dr. Wilson attempted to explain what we were witnessing by suggesting that Jessica might be experiencing some form of anesthetic awareness, but her physiological responses contradicted this theory. Patients who experience awareness during surgery typically show signs of stress, including elevated heart rate, increased blood pressure, and changes in brain activity that would be detectable on our monitoring equipment. This is beyond anesthetic awareness, Dr. Wilson admitted. Her physiological responses indicate that she's adequately anesthetized from every measurable standpoint, but her consciousness appears to be functioning independently of her physical brain activity. As we worked to complete Jessica's surgery, she continued to provide insights that demonstrated not only medical knowledge, but also an understanding of surgical decision-making that seemed impossible for someone without extensive training in trauma surgery. Dr. Martinez, when you repair my splenic laceration, you should use absorbable sutures rather than permanent ones, Jessica suggested. The tissue quality in that area will support healing better, with materials that will dissolve as the organ recovers. Her recommendation reflected sophisticated understanding of tissue healing, suture selection, and post-operative recovery that would typically require years of surgical experience to develop. Yet Jessica was a 24-year-old graphic designer who had never been in an operating room before this accident. The surgery continued for nearly 3 hours, during which Jessica maintained her impossible consciousness and provided ongoing commentary that proved invaluable to her surgical care. Her predictions about anatomical variations, potential complications, and optimal surgical approaches were consistently accurate and helped guide our decision-making throughout the procedure. As we prepared to close Jessica's abdominal incision, something began to change in her level of awareness. The clarity of her speech started to diminish, and her responses became less detailed and precise. Dr. Martinez, I can feel myself settling back into my body, Jessica said, her voice becoming softer and less distinct. The view from above is starting to feel more connected I am to my physical fading and form. What do you mean by settling back into your body? I asked, beginning to understand that Jessica, though I was his consciousness, had somehow been separated from her physical brain during the surgery. It's hard to explain, but during the surgery, I felt like I was floating above the operating room, watching everything from outside my body. Now I can feel myself being drawn back into my physical form, and the expanded awareness is fading. Within 20 minutes of making, transitioned from her state emergence from anesthesia. Her responses this observation, Jessica Hay of impossible consciousness to what appeared to be normal, became typical of a lost the remarkable anesthesia, and she patient recovering from general medical knowledge and hospital-wide awareness that she had demonstrated Jessica to Thed throughout her surgery. By surgical intensive care unit at the time, we transfer 245 post-operative returned to what AM Shiha seemed like normal was drow consciousness. Shisai, slightly disoriented from the anesthesia, and showed no signs of the extraordinary awareness that had characterized her behavior during the surgical procedure. The transformation was so complete that when I visited Jessica in the ICU the following morning, she had no memory of being conscious during her surgery, and no recollection of the detailed medical commentary she had provided throughout the procedure. Jessica, do you remember anything about your surgery last night? I asked as she lay in the ICU bed, still groggy from the anesthesia and pain medications. Not really, Dr. Martinez. I remember the accident, and then I remember waking up here this morning. Everything in between is just a blank, she replied, looking genuinely confused. Was there something I should remember? I described some of the things she had said and done during her procedure, explaining how she had provided detailed medical commentary and accurate predictions about her own injuries and other hospital operations. Jessica listened with growing amazement, but showed no recognition of the experiences I was describing. Dr. Martinez, I don't know anything about medical terminology or surgical procedures. I design websites and marketing materials for small businesses. I can barely handle watching medical shows on television without feeling queasy, she said with a weak laugh. Are you sure that was really me talking during the surgery? To test whether any residual medical knowledge remained, I asked Jessica some basic questions about anatomy and surgical procedures. Her responses confirmed that she had no medical knowledge or training. She couldn't identify basic anatomical structures, didn't understand medical terminology, and showed no awareness of surgical principles or techniques. Yet during her surgery, Jessica had demonstrated expertise that would have impressed attending surgeons with decades of experience. She had accurately diagnosed her own internal injuries, predicted anatomical variations, and provided sophisticated insights into optimal surgical approaches and post-operative care considerations. Over the following days, I became increasingly obsessed with understanding what had happened during Jessica's surgery. I reviewed our electronic medical records, studied the anesthesia documentation, and researched medical literature for similar cases of conscious awareness during surgical procedures under general anesthesia. I found scattered reports of patients who had experienced various forms of awareness during surgery, but nothing that described the comprehensive consciousness and impossible medical knowledge that Jessica had demonstrated. Most cases of anesthetic awareness involved brief moments of sensory perception rather than sustained, coherent communication and detailed medical commentary. I consulted with Dr. Wilson about the anesthesia aspects of Jessica's case, hoping he might have encountered similar phenomena during his 15 years of practice. He had documented everything meticulously, but couldn't provide any medical explanation for what we had witnessed. Sarah, I've administered anesthesia for thousands of surgical procedures, and I've never seen anything like what happened with Jessica, Dr. Wilson told me during one of our discussions. By every measure we have for assessing anesthetic depth, she was adequately anesthetized throughout her surgery. Her brain activity monitors, vital sign responses, and physiological parameters all indicated deep unconsciousness. But she was clearly conscious in ways that our monitoring equipment couldn't detect or measure, I replied. How is that medically possible? I've been thinking about this constantly since her surgery, and I honestly don't have an answer. Jessica's case challenges our fundamental understanding of consciousness, anesthesia, and the relationship between brain activity and awareness. Dr. Roberts, who had assisted throughout Jessica's surgery, was equally puzzled by her extraordinary behavior during the procedure. He had witnessed her accurate predictions, sophisticated medical insights, and impossible knowledge firsthand, but couldn't reconcile what he had observed with his medical training. Dr. Martinez. Jessica provided surgical guidance that helped us identify and address complications we might have missed, Dr. Roberts said during one of our post-operative discussions. Her suggestions about surgical technique and anatomical considerations were consistently accurate and helpful. That's what makes this so disturbing, I replied. She wasn't just conscious during surgery. She was actively participating in her own medical care with knowledge she shouldn't have possessed. Do you think there could be some scientific explanation we're overlooking? Dr. Roberts asked. Maybe there's research about consciousness during trauma that could help us understand what happened. I spent weeks researching theories about consciousness, out-of-body experiences, and altered states of awareness that might explain Jessica's surgical behavior. Some researchers had proposed that consciousness might not be entirely generated by individual brains, but could involve access to information fields or collective knowledge that exists independently of physical neural structures. Other theories suggested that extreme trauma or anesthetic drugs might sometimes allow individuals to access expanded states of awareness that transcended normal sensory limitations. But none of these theories could adequately explain Jessica's specific experiences or provide a framework for understanding how she had gained access to detailed medical knowledge and real-time hospital information. Jessica's case also raised disturbing questions about the nature of surgical consent and patient autonomy. If patients could maintain forms of consciousness during surgery that we couldn't detect with standard monitoring equipment, what were the implications for informed consent and patient privacy? Most troubling was the possibility that other patients might be experiencing similar states of awareness during surgical procedures without medical teams being aware of it. How many operations might involve conscious patient participation that goes unrecognized because patients don't vocalize their experiences the way Jessica had? 3 weeks after Jessica's surgery, I made the decision to present her case at our monthly surgical morbidity and mortality conference, hoping that other surgeons might have encountered similar phenomena or could provide insights into what we had witnessed. The response from my colleagues was mixed. Some were skeptical of our documentation, suggesting that we might have misinterpreted Jessica's responses or that there could have been technical problems with our anesthesia monitoring equipment. Others were intrigued by the case but couldn't offer explanations that adequately addressed the medical impossibilities we had observed. Dr. Patricia Hayes, our department chief, listened carefully to my presentation, but remained cautious about drawing conclusions from a single case. "Sarah, what you're describing is certainly unusual, but we need to be careful about attributing supernatural explanations to medical phenomena that might have rational causes we haven't identified yet." "I understand your caution, Dr. Hayes, but I've reviewed every aspect of this case multiple times. Our equipment was functioning normally, our anesthesia protocols were followed correctly, and Jessica's responses were documented by multiple witnesses throughout the procedure." Dr. Hayes suggested that we consider submitting Jessica's case for publication in a medical journal, hoping that other surgeons might come forward with similar experiences or research that could help explain what had happened. But as I worked to document Jessica's case for potential publication, I realized that the most disturbing aspect wasn't the medical impossibility of her consciousness during surgery. It was the realization that everything we thought we understood about the relationship between brain function, consciousness, and human awareness might be fundamentally incomplete. If Jessica's consciousness had truly separated from her physical brain during surgery, allowing her to observe not just her own procedure, but hospital operations throughout the facility, then every assumption we made about patient experience during medical procedures might need to be reconsidered. Jessica made a complete recovery from her injuries and returned to her work as a graphic designer 6 weeks after her surgery. When I contacted her several months later for follow-up, she remained completely unaware of her extraordinary behavior during the procedure and continued to show no knowledge of medical or surgical principles. "Dr. Martinez, I'm grateful for the excellent care I received, but I still don't understand why you keep asking me about medical knowledge," Jessica told me during one of our conversations. "I design websites and brochures. I don't know anything about surgery or anatomy." The medical team that participated in Jessica's surgery has continued working at Metropolitan General, but each of us has been profoundly affected by the experience. Dr. Wilson has begun researching alternative theories of consciousness and anesthesia, trying to understand whether Jessica's experience represents a rare phenomenon or something that occurs more frequently than we realize. Dr. Roberts has reported that Jessica's case has made him more attentive to patient responses during surgical procedures, looking for signs of awareness or consciousness that might normally be overlooked. He has also begun questioning whether our standard protocols for assessing anesthetic depth are adequate for detecting all forms of patient consciousness. The case has fundamentally changed my approach to trauma surgery and patient care. I now wonder whether every surgical procedure might involve aspects of patient experience that we are completely unaware of, and whether our understanding of consciousness during medical interventions is far more limited than we have assumed. Most haunting is the possibility that Jessica's remarkable consciousness during surgery revealed something that occurs regularly but goes unrecognized by medical teams. If patients routinely experience forms of awareness during anesthesia that we don't detect, it would fundamentally change how we approach surgical care, patient consent, and our understanding of what it means to provide compassionate medical treatment. The impossible consciousness I witnessed that December night continues to challenge everything I thought I understood about trauma surgery, human awareness, and the relationship between mind and body. Not because of what it meant for Jessica's specific case, but because of what it suggested about the nature of human consciousness and the possibility that awareness might transcend physical limitations in ways that medicine has yet to understand or acknowledge. 2 months after Jessica's surgery, I received a call that would add another disturbing layer to this already inexplicable case. Dr. Elizabeth Morrison, the chief of neurosurgery at St. Catherine's Medical Center across town, had heard about Jessica's case through our professional network and wanted to discuss a remarkably similar experience she had encountered just weeks after our incident. Dr. Morrison described a patient who had undergone emergency brain surgery following a severe head injury. Like Jessica, this patient had maintained impossible consciousness throughout the procedure, providing detailed commentary about the surgical technique and demonstrating knowledge of neurosurgical procedures that should have been beyond his understanding. Most disturbing was his ability to describe other medical emergencies occurring simultaneously throughout their hospital, information he couldn't possibly have accessed from his position on the operating table. "Sarah, I've been a neurosurgeon for 18 years, and I thought I had seen everything," Dr. Morrison told me during our phone conversation. But this case has left me questioning whether we understand consciousness at all. The patient had no medical background, yet he guided us through complex anatomical variations that weren't visible on any of our preoperative imaging. The similarities between Dr. Morrison's case and Jessica's were too striking to be coincidental. Both patients had experienced severe trauma. Both had maintained awareness during surgery despite adequate anesthesia, and both had demonstrated impossible medical knowledge while apparently observing their procedures from external perspectives. Most unsettling was that neither patient retained any memory of their extraordinary surgical experiences. Dr. Morrison and I decided to collaborate on documenting these cases, hoping that by combining our observations, we might identify patterns that could help explain what we had witnessed. We began reaching out to other trauma centers and surgical departments, discreetly inquiring whether anyone had encountered similar phenomena. What we discovered was deeply troubling. Over the following months, we identified 7 additional cases at different hospitals across the country where patients had exhibited similar impossible consciousness during surgical procedures. Each case involved severe trauma, adequate anesthesia with normal monitoring parameters, and patients demonstrating medical knowledge they shouldn't have possessed. Dr. Richard Chen at Denver General described a construction worker who had provided detailed guidance during emergency thoracic surgery, accurately predicting anatomical variations and suggesting modifications to surgical technique that proved invaluable. The patient had no medical training but demonstrated understanding of cardiothoracic anatomy that impressed the entire surgical team. Dr. Amanda Foster at Nashville Memorial reported a motorcycle accident victim who had maintained consciousness during abdominal surgery, offering insights about organ viability and tissue healing that reflected years of surgical experience. Like Jessica, this patient had also provided accurate information about other hospital operations occurring simultaneously with his procedure. The pattern was consistent across all cases: severe trauma, impossible consciousness during surgery, extraordinary medical knowledge, and complete amnesia for the surgical experience once the patients recovered. Each medical team had documented their observations carefully, but none had been able to provide adequate explanations for what they had witnessed. As Dr. Morrison and I compiled these cases, we began to notice additional similarities that were even more disturbing. In every instance, the patients had described their consciousness as being located outside their physical bodies during surgery, typically floating above the operating room and observing the procedure from an elevated perspective. More troubling was the consistent report that these patients had access to information beyond their immediate surgical sites. They could describe other medical procedures, predict equipment malfunctions, and provide details about hospital operations that should have been completely outside their awareness. Dr. Martinez, I think we're dealing with something that challenges the fundamental assumptions of modern medicine, Dr. Morrison said during one of our research meetings. These patients aren't just conscious during surgery. They're experiencing expanded forms of awareness that transcend normal sensory limitations. The implications of what we were uncovering were staggering. If consciousness could exist independently of brain function, if awareness sensory input, then every principle could extend beyond physical. We had learned about anesthesia, surgical consent, and patient experience during medical procedures might need to be reconsidered. We decided to approach Dr. James Whitfield, a respected researcher in consciousness studies at Johns Hopkins University, hoping he might provide insights into the phenomena we had documented. Dr. Whitfield had spent decades studying altered states of consciousness and had published extensively on cases where individuals had reported experiences that seemed to transcend normal perceptual limitations. When we presented our compiled cases to Dr. Whitfield, his response was both validating and deeply concerning. He explained that we had documented examples of what consciousness researchers called veridical out-of-body experiences, situations where individuals reported observing events from perspectives that should have been physically impossible, with their observations later confirmed as accurate. What makes your cases particularly significant is that they occurred under controlled medical conditions with extensive monitoring and documentation, Dr. Whitfield told us. Most reports of similar phenomena come from uncontrolled environments where verification is difficult or impossible. Your surgical settings provide unprecedented documentation of consciousness, apparently functioning independently of brain activity. Dr. Whitfield's research suggested that extreme physical trauma or certain pharmaceutical interventions might sometimes trigger states of consciousness that existed outside normal neurological parameters. He theorized that the combination of severe injury and anesthetic agents might create conditions where awareness could access information through mechanisms that current medical science didn't understand or recognize. Jessica's case, along with the others we documented, forced me to confront a reality that medical school never prepared me for. That December night didn't just change how I practiced trauma surgery, it shattered my understanding of human consciousness itself. 2 years later, I still don't have answers, only questions that keep me awake at night. If you're a medical professional who has witnessed something similar, or if you've experienced unexplained awareness during surgery, please share your story in the comments below. Until we understand what Jessica and these other patients experienced, we'll continue practicing medicine with an incomplete picture of human consciousness. Some mysteries in medicine demand that we remain open to possibilities beyond our current understanding, no matter how unsettling they may be.